Okay. Good morning. I'm sorry for the delay because at least there should be some sanity here before this can start. And all these things can also take a bit of time. Um, as per our course outline, we are supposed to continue with our theory aspect of nursing practice today. And thank you all as well for making it a point to join the nursing practice exams. Uh, Everything went well successfully, and I'm very grateful to all of us here. Also, to my Tamale students, you made me had a welcoming stay. I'm very, very grateful. Thank you very, very much. God bless you all. All right, so today we are going to talk about reflective journal in nursing. Reflective journal in nursing. And then you will share a bit of your whatever experiences you've had in the hospitals, any case you'd want everyone to know about, and then your experiences and how best you reflected on it, and then your experiences you had as well. Don't feel alarmed with all these points where you're going to let us all know. Whatever experiences you want to share with us, it's really, really welcomed. So most of it will be from you. I'll just give us a hint about what really is reflective journaling and how best we can use that on our day-to-day practices as nurses in the clinical field. Of course, it's not necessarily about just the clinical field, but wherever we find ourselves as nurses. For me, for instance, yesterday I had a bit of experience where I have really reflected on them all and put a bit of knowledge and learning from whatever has happened to me. So basically, it's not necessarily about the clinical field, but also about whatever we do as nurses, how we can reflect on it. Even other disciplines would also need reflective journaling because based on the theory, the frameworks, it's not even a nurse who framed the framework we use in the reflective journaling. So it means that in other disciplines as well, we can use reflective journaling. Okay. So as usual for me, we are going to talk about a bit about or get to know a bit about some experience or some food for thought in relation to the topic for today. By three methods, we may learn wisdom. And then they say one is by reflection, which is the noblest. And that is what we are going to discuss today. And the other is by imitation, of course, which is the easiest because everyone would want to, in one way or the other, imitate somebody without even knowing it. And the third is by experience, which is the bitterest. Yes, you learn from experience, and sometimes you just even have to cry and then call yourself up. Then later on, you boost up with a lot of energy. Then it means that you picked up some bits about whatever has happened to you. And that is from comfy because we are saying that we do not learn from and we do not learn only from experience, but learn on reflecting on it. Then what else? You wouldn't really pick up those bits where the next time you are faced with all these challenges, you would have to throw away those bits that made you that better person then. Learning is experience, of course, and everything else is just information. Whatever we tell you in class or whatever, it's just about information. You can choose to pick it or not. But mostly when you are faced with the challenges on the walls, challenges outside, and you know that this thing has really made me suffer, and I'll pick these bits from it to make me move along. So, our objectives for today, we are going to understand the concept of reflective journal, explore the benefits of reflective journaling in nursing, and then learn how to effectively engage in reflective journaling. What really is it? what really is reflective journal? Of course, it's a tool for professional development in any field. It's a tool for professional development. So if you pick up whatever experience you've had, definitely you come out with the best. So in terms of your professionalism, you would take something as well. Of course, as we delve into it, we learn more about not necessarily the professional bit, but even for our personal growth as well. So reflective journaling is a process where nurses engage in thoughtful and systematic self-reflection about their experiences, actions, and decisions in the context of nursing practice. Of course, we are talking in nursing, and so everything should boil down to our nursing practices. So whatever nurses engage in, you have to sit back, analyze what has happened or what even is about to happen, especially with patient care. That is why we've learned about the nursing process, where we have to plan our care for patients. So you sit back and systematically jot down the things you're supposed to do for the patient, and then also what has already happened. You jot down, even sometimes you can't necessarily even write it down, but in your mind, in your process, your thinking process, you realize that this I did, this I that. Is it on the right path? Can I change it in a way? So that's all about reflective journaling. So what is the importance in nursing practice with regards to reflective journaling? Self-reflection. Self-reflection. Nurses use reflective journaling to explore and analyze their thoughts and feelings about specific situations or experiences. So self-reflection. I think I've explained during the definition and all those things. So you sit back and then reflect on the things you've done, the things that are supposed to be done based on your thoughts, your feelings, and even you can put that in the write-up. And very soon you will learn about how to write up a reflective journal. For critical thinking. Critical thinking, I know I still owe you an audio, a video, or whatever, like a class on critical thinking. I'll do the video before the semester ends and before we write our exams. Reflective journaling encourages nurses to think critically about their actions and the outcomes of those actions. If we incorporate reflective journaling in everyday activities in the our nursing profession, we know that whatever we are doing, we will sit back and get the nitty-gritties, the negatives and the positive. Next time, we will be a better person. We will be a better person. So that's all about the critical thinking and reflective journaling. Then we talk about professional growth. Professional contributes to the ongoing professional development of nurses that allows them to set goals, track progress, and identify areas for improvement. Areas for improvement. So you know that whatever I am doing, do I really even need a workshop to improve upon my skills? We always do appraisals at the end of the year. And mostly for appraisals, typical of nurses, we just want somebody to finish up and then we take that person's appraisal and then do a cut and paste and then submit. But do we sit back and appraise ourselves? This is really what I know how to do best based on my job description. Let me write that in my appraisal. And we have a column in our appraisal where we have to write for necessary training. So now I would need this. So if we really do a better reflective journaling, we would know that after everything, I need improvements in this. Nurses for a workshop, for instance, we don't even like going. On the wards, if you are tasked to go for workshop, then you'll be running away. Sometimes it's or is there item 13? You are going to get knowledge for yourself and you're asking about item 13 or the time they will close. And all these things in clinical field especially, we don't attach importance to workshops. When you go up the academic ladder, you realize that workshops is very, very, very important. No matter how far you think you know, you still have to add on. You still have to add on. And for professional growth, reflective journaling helps us to know better, and then the things we are supposed to improve based on where we find ourselves. Of course, enhancing patient care, enhancing patient care. So through reflective practices, nurses can identify ways to enhance the quality of patient care. The quality of patient care. You are sitting back to know that the thing, whatever I did for my patients, did I do it right? Of course, if you sit back, analyze it, and you realize that there are things that we have to be honest to ourselves. Sometimes there are things we do for our patient. We go back and we're like, hey, I could have done it this way, even though it didn't really harm the patient. But you think that, oh, if you had done it this way, it would have been better for the patient. Sometimes also, you knew that whatever you have even done didn't really yield any positives. But then if you had done it this way, maybe there would be a better positive yielding for the patient's care. So it enhances patient's care as well. Of course, we talked about professional growth. And so you know that, oh, okay, I have a shortfall in whatever thing based on the field I find myself in nursing or the ward I find myself in. And so when you go and you improve upon that, of course, you come back and it's the patient who gain the benefits. Yes. We talk about ethical considerations. Ethical considerations. So it provides a platform for nurses to explore ethical dilemmas they may encounter in their practices. So I've said that it's not necessarily about you are done with whatever you are doing for the patient, sitting back to reflect. But sometimes, even before you do certain things for the patient, you have to reflect and then think through before you see whether you should do that or that. Sometimes on the ones you are faced with challenges, a lot of challenges that we all know that nurses, we are magicians. We do a lot. We are faced with challenges whereby we if we give in to any other discipline in the health profession, they may not even be able to do them. Sometimes there's even one drug in the emergency treatment cupboard, whatever, where you have about 2 or 3 critically ill patients. You have to even share or give a drug to one person, or you have to attend to about 3 or 4 patients calling you. You have to assess which one you have to attend to first. And all these things are part of the ethical consideration. You think through so that in any case, if that other party you attended to the third time or the second time, if there's any issue, you know that you will be justified. So we have a lot of ethical dilemmas in our nursing profession. And you and I know all these things. And so very soon we will open up the floor for us all to share whatever we think we can share for us to learn bit about it. For personal well-being, personal well-being. So they are saying that beyond professional development, reflective journaling also supports nurses in addressing the emotional and psychological aspects of their work. We all know that you go home and you still think about the patients on bed too. You go home and you still think about the patients who came in with whatever condition. You go home and you be calling your police. Also, this patient, what's really happened? Sometimes let us take a break. Let us take a break because I've always been saying, even though we have to talk about best way you can take care of our patient, also you have to think about ourselves because for us, no one think about us as nurses. You and I know no one think about us. So it's all about us and how we can improve upon wherever we find ourselves. So, of course, as I'm saying, I'm just trying to link it to how best we always put our emotions to care for our patients. We put our emotions to care for our patients. And so if you do best for your patients, you feel satisfied, you feel good, you feel okay. Oh, you were able to, this patient was even going, and then or was maybe patient gasping or whatever. You did this, you did that for the patient, and the patient was fine. And now the care given to the patient is optimum. So all those things are part of our personal well-being as well. Let's try our best and inculcate reflective journaling right from today in wherever we find ourselves. Wherever we find ourselves. How to start reflective journal. So you choose a medium. Are you going to do digital? Of course, now technology is evoked. Or are you going to do paper writing? Or even your thought process? Are you going to sit back and think? are you going to do that? Set aside dedicated time. So sometimes we call something meditating, you all know. So it's not about during the chaos. Of course, we have a bit about the reflection in action where we learn that in clinical judgment. Yes, it happens. But really, if you want to do reflection on action, the proper reflective journaling after the incident, you have to get time. You have to get a quiet, comfortable place where you can sit back, think through whatever has happened, and then state it as the process is given to us or as the stages is given to us. We state it based on that. We have prompts and frameworks where we are going to use that to write our reflective journaling. What really is prompts? What really is prompts? So reflective prompts, they are specific questions or statements designed to stimulate reflection on a particular aspect of an experience. So this helps individuals think deeply about their actions. What have we done for the patient? What are we doing for the patient? We think through so much. Your actions, even your reactions, and as well as your outcome of whatever situation you find yourself in. You think through. So these are the questions and statements that will guide you to know the actions and reactions and the outcome of that experience. Then the prompts encourage individuals to explore different dimensions of experience, such as the emotions, challenges, ethical considerations, and the personal growth. Personal growth. So, in a way, it can be an open-ended questions or statement that will guide you the next writing whatever or thinking through whatever towards a more profound understanding of that event or whatever that happened. So based on open-ended, we know open-ended questions, things that will get you probing further to know what really happened or to know more about that situation. That is open-ended question. So you open up. So what should I have even done then? It's not something you have to just get, oh, okay, yes, I did it. Oh, okay, no, I couldn't have done it then. No, it is questions that will answer the whys and then the hows of every situation. So prompts. Who will just open the floor for us today, describing a challenging patient interaction and how it made him or her feel. Who will open up the floor, describing a challenging patient interaction and how it made him or her feel. The floor is open, please. Or maybe also you can share us or tell us something about you reflecting on a situation where you had to make a difficult ethical decision. A difficult ethical decision. So tell us about it. Or a challenging patient. You know, we have patients who are quite difficult sometimes. I've always been saying that nursing a teacher, nursing a lawyer, they are very difficult. And the teachers mostly, this is the teachers in the primary schools who are very energy agents, they are very, very difficult. They think they know everything. If you get the chance to meet these kinds of patients, sometimes they are very challenging. They think they've gone to on Google to read all about their condition. Meanwhile, not all things are good on Google as well. So who have next? Harriet. Harriet Apre. Okay. So yes, what do you want to
Hello.
share? Yes, good morning, Harriet. What do you want to share with us, please?
One challenging situation that I don't know, I never knew it was a reflective journaling that I was going through.
Okay.
But this particular patient came to our hospital. Initially, I was at Volta Regent then, and then
Okay.
she had no money on her. Her condition was so severe that she
Okay.
needed admission. She pleaded with that to take care of her on OPD basis. But the way she was weak, we couldn't let her go. So we admitted her. because she didn't have money, the prescriber only prescribed them promethazine and then some anti-malaria because the
Okay.
malaria test we did came out positive.
Positive. Okay.
This lady, yes, please. This lady was so weak that she was taking in malt. She couldn't eat anything. But when she's vomiting, she vomits some greenish vomits instead of black. We were expecting the malt to be seen in her vomits, but we were
Okay.
seeing greenish things. So we saw that, and then she was very anemic.
Okay.
And we called the relatives, but no one was even willing. I remember the mother and the father were both dead. And the auntie who was taking care of her was even tired because she's always sick. So I think she's even tired of. So we called them and they were not coming. But this lady needed referral because my institution was a clinic then. We called and no, so something was telling me, oh, why don't I go and arrange blood for her? When I went to the lab, they were telling me that she was owing and all that. She hasn't even settled her consultation things. And I ready to pay for the blood. At that time, I thought of it and I was like, no, I don't really have money. So why am I even going to look for problems for myself?
Okay.
And so later on, the relatives, we called them like 2 hours, they were not coming, 3 hours, 4 hours. This lady was getting weaker and weaker, vomiting greenness. We were actually losing her.
Mm-hmm.
So we forgot about everything that we gave her blood. When we were giving her blood, she was reacting seriously. She had these rashes and all that. So we had to stop the blood, take it back to the lab and all that. So the relatives were not coming. When they finally came, the lady said she doesn't have anything on her, but this lady needed referral to a bigger facility to Trafalgar. So we had to we stopped the blood and we gave the girl to the woman. She didn't have
Mm-hmm.
anything, and the only thing we could think of is to take her phone so that later on she come and say, "Please do." And then she died on the road. So
Wow.
I sat down and then I was like, what didn't I do? What could I have done that would have prevented this? So
Reflect.
I think I had. So I kept on even up to now. I still reflect on that situation. What could I have done that would have really caused a change that wouldn't have made her die at a very young age like that?
Wow.
Thank
Wow.
you.
Wow. Thank you to Ed. That's a very emotional experience. Emotional experience. And then with your reflection or the bits about what we have discussed, um, you realize that in a way you've become sort of emotionally attached. Once in a while you think about it, but at least you did your best. If at that very moment, I don't know if contributions are welcome, you just give that promethazine and then patient is vomiting bile content. So why would you just give promethazine and you feel that the patient will just be okay? And testing for malaria, you feel that patient, almost all of us walking around, you want to test for malaria, you can get a positive. And so it was really something else. Because if we had referred the patient and gotten to wherever bigger facility, you would have realized that it's either an emergency surgery that would have even been necessitated for the patient. So you did your best, and of course, you lost the patient. So you sit back and then reflect. Of course, as you said, what should I have done? What shouldn't I have done? But at least the bits that you did were the best for you. I see you're emotionally attached. So our personal well-being is also at stake. As you think about it, you have a lot of things to think about. Why do you have to still think about this patient? So these are the things we are talking about that we have to really be careful as to what we do for our patient and what not to do for the patient so that we can't be emotionally attached. The bit about the thing you did in terms of going and arranging for blood, they are saying the patient doesn't have money also. That is also part of the work for a case manager. If you're a case manager, ideally a case manager would have to do um, um, get an optimum care for the patient at a low cost or at a cost that the patient can offer. That is the work of a case manager. So all nurses should be case managers. Of course, sometimes in the wards, you can we have an assigned case manager. I think in the developed countries, you have a course you do on case management where almost all wards, there's a case manager, a nurse, manager as managing cases. And so they see to it that patients who don't even have money are still given this optimum care at their rate, at their rate. So you don't just say that, oh, because the patient doesn't have money, you just want to link the patient. And that is his or her phone or whatever to see if still relatives will come. But I bet you when the patient died, then the way they will run this funeral and get a lot of cash, you wouldn't you'll be surprised. So that's it. You've done well. This is a very inspirational, reflective journal scenario. Thank you very much, Annie. Who else would want to share? Or we can go on and as we carry along, you remember something. Juliana. Okay, Juliana.
Hello, please, can you hear me?
Yes, please, I can hear you
Okay.
clearly.
Okay, so I'll also share my experience as a student nurse.
Okay.
I came for afternoon shift and we had a restless patient. He was on oxygen. So I took him to the washroom to ease himself. Later I came, the relative said he had bitten into the nasal catheter and it wasn't flowing again. So I went to my in charge and asked her for a new one. I went and she said the patient is owing a lot, so she wouldn't give it out unless I pay 10 cedis. And I said, okay, I will stand in for the patient
Wow.
and get it for them. We had to just argue for some time and she later gave it out. I got there, the patient had died.
Wow.
I was just shocked with my my line.
Wow.
We were there. I don't know, but I felt like the patient wasn't dead. So I got there
Mm.
and I said, no, the patient is not dead. So the sister I was working with said they should leave me to do whatever. I took my sphig, started checking BP, checking temperature. She was asking me, what are the values? I said, I'm not getting anything. And she said, okay, we should do the last office. We were doing it as we were telling him. I heard a wheezing sound. I said, no, sister, the man is breathing. She said, no, he's dead. You go and sleep. For the whole night, I just slept and woke up in the morning. I had to just go home because I was in shock. But I was angry with the nurse that because of 10 cedis, maybe if you had given it out, maybe you could have saved their life. But because of 10
What did
cedis,
you say the patient has bitten into? What was in situ that
the
hadn't?
please, the oxygen, the
Okay.
cannula.
Wow. Okay.
Uh-huh.
The nasal prompt.
Okay.
The
Yes.
nasal prong, sorry. Thank you for the correction.
Okay. Wow. So for that one as well, unless patients pays before they can get it.
That time, I don't know, but for the hospital policy, they were paying for it.
Oh, then that's very bad. That's very, very bad for nasal prong. And so that time also you were a student nurse, you hadn't had a lot of experience as well.
I
So
mhm.
what else can you do? And these are the things that we find going on our wards, and that is very bad. Nasal prongs, even it is requested from the medical stores or whatever for each patient. So somebody is saying that it is 30 Ghana cedis even on the limb. And if as a nurse, of course, maybe she has paid for a lot of patients, she didn't get anything in return. But it's just 10 cedis. Just 10 cedis. This is the case where we find ourselves, necessarily we don't have money, we are not well paid. So day, for all you know, she's even on a lot of loans as well. So what else can she do? But of course, that's very, very bad. Very bad. So you can just take it. It's a lot. In some hospitals, it's just lying there, just like that. And sometimes also some even get expired. And they just go and discard them. And patient is receiving the oxygen to help him breathe. And without it, of course, patient will be dyspneic. And it will be a cause for alarm. And that is what happened. For all you know, as he said, patient. So isn't doctors there to certify patient clinically dead before you perform your last offices? Sister Julie,
The
isn't doctors?
doctors were there, but that time I didn't even see a doctor. I'm sure they called him on phone and he told them to do the last office because I didn't see a doctor around. It was only nurses.
Wow. So these are parts of the thing. Thank you, Juliana. I'm
Thank
grateful.
you.
Thank you. Yes. So these are parts of the thing. And you see, she got emotionally attached. I'm sure the whole day she didn't even eat. She went, cried at home and she bathed and then she sleep. Maybe after she woke up from her night duty sleep, and after night sleep, that is where she will feel that, Charlie, I'm hungry. I have to eat something. So these are parts of the things. And they are going on. And recently, one of my friends who just also left where we all were working and now is at the NMC, brought her mother to the hospital. And in summary, her mother died just because I think her kidneys got shut. They had to monitor for strict intake and output. Every day she would go there, and even urine, they haven't even emptied it. Patients wouldn't even be on infusion. A whole lot, a whole lot. Even as at the time she was there, one patient, her mother was even gasping for oxygen. She had to initiate it, and there were nurses on the wards. What are we really doing? What are we really doing? So you just have to think that, so should I have to be in the clinical field always to see if I can take care of my parents or my relatives when they come around? But sometimes also, even when you are found, when you are placed, maybe your relative will also come and then maybe he or she will be at a different unit. And we know ourselves. You go there and then the nurses will be like, of course, you're a nurse and today. You think you're a nurse, and so what? I can we are also necessary. We can take care of your patient. Why do you have to come here promptly like that? You know what you can do. You know what you can do. That is the main reason why always when we bring our patients, we want to be around our patient because you can kill our patient. And then also, most of our experienced nurses are also leaving because the government is not taking good care of us as nurses. They are not. These are some of the things. So me, I'm always happy when I see a nurse traveling to the US and the UK. I'm always happy. They have to go. At least everything you see BBI is in your bottom, is in your pocket. So however you can fend for your family, you have to go. Travel and go. That is it. So somebody says it may be possible the in charge will be confronted and has to account for if payment isn't made. But it's so really sad. Oh, so this patient definitely, patient, even if that patient at the end of the day patient dies, relatives will come no matter what. They will come. When patient die, the way they will come running around for death certificate to be signed, all those are ways you can even get your money. And even if patient doesn't die, patients will be discharged, no matter what patient comes. And we have social workers in our facilities, all facilities, where they can be a mediation between the patient and the relatives. So why not? Okay. So at least the two experiences are all quite sad. There's one bit of my question where I would say that you have to consider a recent success in your nursing practice and the factors that contributed to it. At least I want something positive. Something positive. Sister Elizabeth.
Yes, sister.
Yes, yes.
Sister, please, mine, the two scenarios were ended sadly, but mine, I think, it was a happy ending.
One, yes, I want that. Yes.
There's this, I think within this week or last week, I was on night shift and I had a case. Three gentlemen walked in with a friend. He was having difficulty in breathing. He couldn't even talk. So I was lucky he could communicate and write. So he said I should give them the pen so they can write. The gentleman was able to write his problems, that he's having difficulty in breathing and then coughing up, productive cough and other things. So I was happy that I could at least get something from him.
Yes. Can you continue?
I started he has experienced that for some time now, about 3 times. So I started with the nebulization, but through in the course of the nebulization, the light went off, and I had to be running helter skelter looking for light because I wanted to save him. But eventually, the light came, and when the gentleman was okay, he was hungry. I think because the problem started earlier on, he was not able to eat. He had not eaten anything throughout the day. So later on, he started complaining of hunger. We went, and it was a bit late, 11 something, and we are in an estate. In an estate, they sleep early. So we walked throughout the estate. I called some of the people that have been selling drinks and other things if we can get something. Even the Okada man that brought them also ran out around the village to find something, but they couldn't get anything. So they decided to go back to where they came from, a nearby village they came from, so that they can go and prepare something for the gentleman. I said, oh, if that is the case, then my house is just close by the clinic. So let me go home and then prepare something for, if only he will accept. He said, oh, madam, if only you did that for us. I said, oh, no problem, I'll go. And so I went home. I was lucky. I picked condo from the fridge in the morning. So it had thawed. I went home, prepared the condo. I had a little milk left. My kid had drank everything. So I had a little left. I said, yeah, I'm lucky. I took it and I brought sugar and added some Milo if only is interested. I was not having bread. I took biscuits and I added. He was able to eat it. In fact, they were happy. So when I came, the gentleman asked me, Madam, I said, I attend the Church of Pentecost. I said, hey, we are also Church of Pentecost members. I was like, okay, then it's good. Then they were very happy. Sometimes I think we have to go out of our way to take care of the patient. It will sometimes cost us, but I think it's the best. Sometimes normally I put myself in their shoes that I could have been in that same position, my mother, my father, or sometimes our kids. They could have been in that same position. So if we do it for them, somebody will also do it for them someday, sometime. And sometimes I also think about it that this gentleman could have afforded it, and they could have had enough food in their houses. But this is the situation where he cannot get something to eat. Why don't you go and then get him something? I went and then he was very happy. In the morning, I came back to look for him, and then he said, oh, I'm okay. I want to go back to my work. I said, we thank God.
That's
is
great.
all.
That's great. That's great. That's great. Thank you very much. At least now I've smiled.
Yes.
Yes, that's great. Yes. So we all have to go the extra mile to take care of our patients. Of course, we know the government doesn't take care of us, but what else can we do? It is something that we have vowed to do. We have taken an oath to do, to care for our patients. So that is it. Thank you very much, Sister Elizabeth, and I'm glad. Yeah, so Michael is saying some of us, our experiences are scary. Imagine a house officer declaring a patient. Yes, and that is bad. A house officer will declare a patient, you see, and later patients even coughed, clinically dead. They don't know anything. House officers are just like rotation nurses. Can you imagine? They are just like rotation nurses. They know nothing. But mostly, even we nurses, even we the ones who have even spent more time in the clinical field, we see house officers and want to go talk to them. What nonsense. Seriously, it's very bad. They don't know anything. But I want to just make them as if they are gods. What the hell? It's very bad. They don't know anything. So please, we have to be careful as who we, I don't know, give whatever respect to. Of course, respect is earned. And if they are elders, they're specialists or whatever they are elders, we can just give them that elderly respect, but not because they are doctors. They have their discipline. We also have our discipline. We are not under them in any way. But somebody will see a house officer and would want to. They can even send them to go and buy granules and wachi for them. Can you imagine? And then, yes, next as a football dance, yes, you did so well. So somebody is saying during my service 2017, I met a man with a snake bite for almost 3 days. Patient was lying. So I think most of us have read these ones, right? Yes, so we can read all the chats in the messages as well. It would give a bit of insight to us all. That's great. All right. Then we move to the reflective frameworks. Now, we are going to use these frameworks to guide us as to how to write a better reflective journal. Ideally, like all the experiences we have and we've shared now, we can write them down, then later think through. As you all were saying that, is it something I did better or something I did bad? If it is something I did better, I can maybe even improve upon it. Improve upon it. Sometimes it's not about the money. Yeah, is it yesterday? Someone was just trying to tell me that sometimes it's not even about maybe you've done this and they say, oh, take money or whatever. But sometimes all the God bless you, some years to come, those God bless you will do something better for us. Of course, now the system is hard. We all want money. But sometimes also let us consider other bits of it and not necessarily about the money. Are we clear on that? And that will also be better. Okay, please, who is it? Somebody say, even praying with the patient is not accepted. Well, so in Ghana, depending on the faith of the patient. All right, so reflective frameworks, frameworks are sort of protocols or guidelines or even models to help us in the things we are supposed to do based on the topic under discussion. So for here, we are saying that reflective frameworks are structured models or processes that provide a systematic approach to reflective practices. So they often consist of stages and steps. So as I said, they are guidelines that will guide us as to writing a better reflective journaling. Frameworks helps individuals break down the reflective process into manageable components. So this one, we've all said it generally. So we are going to discuss the framework. Then afterwards, we also see if we can open up the floor for another case scenario. And then based on, even if you can't take everything, all the frameworks we've discussed, you can take some bits and then based on that, share out your experience as well. So we are saying that it's a reflective process into manageable components, making it easier to analyze and learn from our experiences. So for reflective journaling, these are the authors who have made some frameworks that are useful for our day-to-day activities or our daily activities based on our write-ups in reflective journaling. Gibbs' reflective cycle, that's the first one, and so that is quite the common ones when you want to read books on reflective journaling. John's model, John Dewey, I think one of the key quotes I stated at the beginning, his is part saying that learning is just, all other learning is just information, but learning with experience is rather the ultimate learning. So John Dewey also is part of whoever wrote the reflective journaling frameworks. And then Borton's is also part of them. There are 3. Maybe the current ones you see, they are just adding up to these main ones. Maybe if you want to read further and you see a different framework, but these are the basic frameworks we use when we talk about reflective journaling. And I have said that the Gibbs is the first one. And we are saying that for Gibbs, mostly we talk about that in the next slide, where he talks about the description of the event and the feelings, how you felt, how you evaluate the evaluation, the analysis, you conclude how conclusive the event all came up, and then the action plan. So what are you going to do next when you are faced with such a situation? Or what could you have done better? So this offers a comprehensive approach to reflection, and that is for the GIPS. And for the Jones, the next one, the Jones model, he's also saying something on just describing the experience as well. And reflect on the feelings and thoughts. So it's almost like the GIPS. Yes, the GIPS is about 6 or 7 steps, and then the Johnsons have just collectively put them all into each. They are overlapping in each other. So you describe your experience, you reflect on the feelings and thoughts, the influencing factors, and then you also evaluate your experience, you analyze it and conclude. Then the last bit, that's the Bolton's reflective model, he's saying, so what's really happened? So it means that he is also talking about description. Then, so when it happened, so what happened again? So what? So it means that you also have to analyze it. This happened, and so it's like you wanting to take a qualitative data. You want to ask more questions, probe more. Yes, and so you analyze it. And now what happened again? That means now the conclusion and your action plan is also part. So all of them are used, the prompts and then the frameworks can be used together or can be used separately. As in the prompts, getting that open-minded or open-ended questions to answer your bits in the event, and then the frameworks where you talk about why, what, and then your action plan also. They can be used together, depending, of course, on you, the individual's preferences, you as a nurse. If you want to sit back and just use only the framework to describe your feelings and everything and your action plan, you can. Other than that, you can add on the prompts as well. And they all serve a valuable tool to facilitate a meaningful reflection process during your profession and also your personal development as well. So this is for GIPS here, GIPS reflective cycle. So GIPS is saying that description, the feelings, evaluation, analysis, conclusion, and your action plan. So the description, they are saying that you have to give a detailed and objective account of whatever happened, your experience. So if it's a positive feeling, if it's a negative feeling, or maybe helping you, the writer, to gain that deeper understanding to whatever event that happened. So that is all about you describing it. So what really happened? What really happened? So you keep it relevant to what happened. That is the description. Maybe Mr. So and so who came in as most of us have described, and then maybe coughing, this neck, and I had to manage that patient. So that is the description of the event. That is the description. So what happened? So you put your feelings into play. So you reflect on your emotional response. So you quickly want to do something for the patient. So your emotional response and your reactions during that experience, that is your feeling. So it will help you express both your positive feelings and then your negative feelings as well. I'm sure with the other two that were quite sad, in one or the other, some of you may be furious. You would want to even maybe talk back at the person where you were going for the blood. They say the patient doesn't have money or what. I'm sure you'd want to even insult the person, but maybe you held back. So all these things are quite negative experience or negative feelings. You'd want to also write down when you're writing a reflective journaling and see if did you really even show sign of maybe anger to your colleague, or you didn't. Then you sit back and see if you showed, how best are you going to improve upon it, or how best can you also do something better for them to know that next time they can't also say this. Sometimes if it's about patient health, it's not necessarily about the playing the good person. Tell them your peace of mind and then let them tag you. Yes, let them tag you. At the end of the day, you are tagged, you don't care. The time will come, you just leave wherever they feel they can just take that place and swallow. That's for themselves. So it's about the positive feelings and the negative feeling. So that is where you gain that better understanding to that event that has happened. How did you feel? What were you even thinking at that time? And then looking back as well. Then we come to the evaluation. Okay, somebody is also writing his bits here. All right. Then we come to the evaluation. You critically have to evaluate the experience. Consider how it went. Did it go well? What could have been improved? You see, this is where you balance the assessment of the situation itself. That one also you add on, or you put in both your positive and then the negative aspects as well. How the things really go. Did it go well? Did it go bad? And then the reactions again will come into play in evaluation. That's one. You have to know reaction for yourself as well, and even the others involved. Whatever they also felt or they also did or they also reacted has to come into play. Then you want to now analyze the situation. That will also give you a deeper exploration of the experience. Okay, so afterwards, then what else? So you see that is why, Gibbs is 88 or something, and then the Jones and the others are 90s, the 90s. So put them, you realize that the feeling, the evaluation analysis is almost like the same. So that is why some of them, the other ones, just classify them into 3 groups. They're almost the same. So that one too, it encourages you, the individual, to examine what's really contributed to the outcome, the positive outcome or the negative outcome that he ordered. What's really what personal beliefs you attach to it. You see, one of our sisters said she even went home to cook. It's just a porridge. And then of course the house is closer by. Of course, if her house wasn't close, I'm not sure she would have gone, but maybe she would have see if she would have gotten a different alternative to that as well. So your personal belief comes into play. We've learned that after everything, our personal well-being is involved. Now, this sister will be happy all throughout. But the other ones, you see, they will still have to reflect and it will get back to them. So if now that one of them was a student nurse, currently she's working. And so if she's faced with certain situations like that, where one of her colleagues do something in relation to whatever happened when she was a student, you can just imagine what will happen on the ward that day. Maybe she will just flare up and it will cause a fight or something, a cause for alarm. Then you have to conclude on your bits. Conclude on everything. Okay, so it means that in my conclusion, this is the final bit. This is what happened. And so now action plan. So if I'm faced with the similar situation next time, what am I going to do? Am I going to do something better? The vomiting of the bile and bile content, of course, and the passing away, they're going for their blood. So afterwards, so the next time I'm faced with this, currently, what do I do? What do I do? Am I going to just there and then admit patients and maybe start some IV therapies and then later refer patients myself, look for, I don't know whether it's a CHIPS compound or a municipal hospital, look for a PA or look for a doctor or whatever. If they are all not there, I can just write now. Referrals, most of the referrals that even come to a teaching hospital, sometimes it's a nurse who will write it. Because sometimes you are faced with challenges so much so that you can't wait for whoever doctor they call themselves to come and then write whatever they. Maybe they are just doing some locums somewhere. The way they like doing locums, they just go out there, do their locums and whatever. And you are just left there. You call them, they'll tell you, oh, do this for the patient. For sometimes you have to come and assess. Use your other medical eye. We are using our nursing eye. That is why it's a teamwork. So use your medical eye to also come and assess. So if there's something else we are supposed to do for the patient, before even we refer the patient. So all these things, you have to sit back and then you would have to see that, okay, next time, what am I going to do better for myself? Okay, so somebody said people will lead you into trouble. So that would be the action plan. Then afterwards, what else? Okay. So now we are going to discuss a scenario where resource limitations affected your ability to provide optimal care. So that is about the one with the nasal prong. So it means that one is not a resource limitation. No, it was there, but they were talking about cost. We're talking about costs. So now, what are you going to discuss where you had shortage of resources or limited resources, and it affected you giving out your optimal care? Your optimal care. Nuruddin says I should recap. Okay, so I'll let somebody recap for us the GIPS framework for reflective journaling. Who would recap that for us? GIPS framework of reflective journaling. Who will recap that for us? Anyone? Anyone? Whoever said our network was bad, so we need a recap. So if whoever understood it well can explain it to us. If by chance they're explaining and I have to come in, I'll do that. Other than that, I think it will help us a lot. Who would? No one? Okay, so we are just saying that we have the description, you describe the event. You describe the event as to giving a detailed objective of whatever happened, detailed account of the event. So I was faced with treating maybe Mr. So and so, a 65-year-old man with, let's say, hypertension and maybe with BP of whatever, and then restlessness, who is dyspneic, and then maybe with and then coughing as well. So I was supposed to manage the patient maybe alone or maybe at a particular time, just describing what happened. And you keep it so relevant to the point. You go straight to the point. You just give that background information about what really happened, or what the event is, or what the event is. If you are now going to take care of that event, or if you had already taken care of that event, you give a description about what really was the event. Now you come to the next stage in the reflective framework of GIPS, where we say that feelings, where you have to give an emotional response based on how you, the first reaction when you are assigned that job, or when you are assigned, you face with that situation, that emotional response, that reaction during that situation. And that's about your feeling. How did you feel? What were you even thinking at the time? And then looking back as well, what did you feel when you were managing that patient or that case? That is about that. Then you go to your evaluation. Go to evaluation where you ask, how did things even go? Was it good? Was it bad? So that is where you are going to balance all your assessment. You assess your situation where you put in the positives and then the negative aspects as well. Bring them together and ask yourself, did it go well? Can I do better? Is it good or bad? The reaction from yourself and even from others. You also have to analyze things. Now you analyze based on your personal growth, personal development. So what factors really contributed to the outcome? We have said that evaluation, you're going to check whether it went well or it didn't go well. Okay, fine. If it went well, what really are the factors you did that contributed to that outcome, that positive outcome? If it didn't go well as well, so you as a nurse, what factors also contributed or did you put in that contributed for that thing, that experience not going well? Or from the others also, what factors did they also put in that yielded that negative response? Of course, you have to add on your personal beliefs, inculcating that, as I made an example where somebody rushed quickly to the blood bank to go for blood. Somebody else went home to prepare some prayer because the house was just close by the hospital. So depending on whatever you do, your personal beliefs is at stake, your professional development also is at stake. And then you come to conclusion. Okay, now it is concluded that this was my outcome. This and this. So that is also quite straightforward in terms of the description as well. You just conclude that this and this and that was the outcome. So the next thing will be my action plan. So next time I'm faced with this same situation or similar situation, what am I going to do? So it means that after all, everything, you're going to learn something from whatever event that happened. Whatever event that happened, you're going to learn from that. Both the negative and the positive, you still will learn something. So that the next time you are faced with certain challenges similar to that, you know what to do. Mostly also, so as I said, you can sit back, that's reflection on action, where after everything you sit back and reflect and then write them down. Or during even the event, during that experience, that the reflection in action, where I said we discussed it a bit during the clinical judgment by TANOE, where we say that reflection in action, when you are doing the bit on the patient, you can as well reflect as to the things you're supposed to do for the patient and what you're supposed to do next when you're faced with these challenges. So now we come to case management, where we are saying that based on resource limitations, what can you describe that affected optimal patient care? And the next one, you also have to want somebody else want to also share experience where you reflect on how you manage to allocate resources effectively. Of course, with that same, I think is that with that same first point. So you discuss the scenario with that resource available. How did you really allocate these resources? So I made a scenario during our lecture that sometimes it's not even about resources, but it's about you alone, the human resource. You have about 3 or 4 patients calling out to you. You have to prioritize these patients, see who you are going to go to first and next. Then later on, think about the ethical dilemmas and ethical considerations as well, so that in any case, if the second or the third patient you attended to has any other issues, it wouldn't necessarily be like because you attended to that patient the third time or the second time, that is why this patient had those issues. So this one is in terms of resources, limitations of resources. Who will help us? Limitations of resources. We were faced with a challenge where we had patients, but whatever items we were supposed to use were on the low. And how did you allocate those resources? So as far as the analysis is the same as the lessons learned. Analysis is where you're going to know what really was the outcome. So it is the analysis and then the conclusion. So the outcome of the analysis and the conclusion will be the final bit. I'm still waiting for our experiences, but we have to move on. If no one will share, then I'll just go to the next slide. Okay. So another one, but the first one, no one even responded. Describing a case where you had to manage the care of a patient with multiple coexisting health conditions. Reflect on the challenges of prioritizing your care. So this is before the event. You've been faced with it, but you haven't necessitated any interventions. So how are you going to plan your care? So you are faced with a patient with maybe about 2 or 3 conditions. How are you going to prioritize your care, coordinate interventions, and ensuring a patient-centered approach? And then your lessons learned. Of course, after you are done with the patient's care, what were the lessons learned? And all these things, it has to be under the GIPS framework. GIPS framework. If you can't discuss it online here, maybe afterwards and after you get your slides also, you can just sit back and then write the stages for experience based on the GIPS reflective cycle. Nuruddin, is your hand up?
Good morning.
Good morning, Nuruddin.
Please, I had a case management related to this in 2022. That's last year.
Okay.
Where a woman 53 years of age, which came on admission at the female medical ward with the diagnosis of HPT and diabetes mellitus.
Okay.
This woman, we checked her random blood sugar, which was 27.2.
Mm-hmm.
Then the BP2 was also monitored and was 200, 160.
This thing, it's really difficult to manage, right? Always we have found one thing that we always pull out.
It was very, very difficult.
Yes.
Now,
it's true.
I asked my senior in charge. Now that the BP is high, at the same time, the random blood sugar is also high. Which of them are we going to manage? Because I thought of like, we have to administer normal saline and give insulin injection, which the doctor was ordered that if it is above 20.0, the RBS, we give 10 units of soluble insulin, subcut. Then we add normal saline. But now, if we give the normal saline, it means that the BP will continue to rise. So now I don't know what I'm going to do or we're going to do. So when I contacted the my in charge for that shift, so she says that now that the BP is high, we can't say it's because of the BP. We should not also intervene for the blood sugar. So we have to call back the doctor. The doctor says, okay, we should give IV hydralazine whilst we also administer the insulin in concurrent with the normal saline. So that was a very difficult task. But we did that. Then the sugar or the blood glucose level, it goes down. Then we're also concentrating on the BP. So later too, the BP also went down. But it was around now 130 something. Then the diastolic 2 was around 90 something. But I think it was a tough case, but we were able to manage it.
It's well. You've done well. You've done so. You said you managed it finally with what?
We gave IV IV hydralazine. But we incorporated it was as 2 meals, which we diluted with aqua, so 8, and in total it was 10. So we have to give half of it, not the whole 10, milligram. So we gave half, which was now 5 milligram. The push stop method that we use. Then later on, we realize that the BP goes down.
The higher the cost of machine, just like they use our.
So that was how we intervened.
Yes, thank you very much. You know, you've done well. You've shared a very good experience, and that's all about today's case or today's topic. So we share experience and we learn from it. This case Nuruddin has shared, for instance, in some hospitals it is managed differently. It will be almost the same thing, but a bit different. You get it? So we share and then we learn from that. We learn from that. It's not basically about the theory where we say, oh, medicine, we are going to learn HPT, and HPT, this is the course, this is the pathophysiology, this is the management. Currently, we are all on the wards, and that's the debate about nursing practice. So what are you doing there? What is someone also doing here? I remember for me, this case, for instance, I have managed some before where it was rather someone here is saying about the Ringer's lactate, for instance. Ringer's lactate, sometimes also you can even use dextrose saline mixed with, and then somebody's also talking about diabetes regimen. That's very true. When you're found with these things, for instance, it's really difficult, honestly, really, especially if you haven't faced it before. You ask yourself, what should I even do? What should I even do? Am I going to serve which medication, which infusion at all? Are you getting it? But unless your hand is raised, if you have any other experience or you want to add up this, I prefer adding up on this Nuruddin's case. Yes.
Madam, please, Nuruddin said that they mixed 8 mils of aqua to 2 mils of hydralazine.
Okay.
So making 10. And then they pushed half, which was 5 mils.
Okay.
So it means only 1 mil of hydralazine was used.
Mm-hmm.
And then they discarded the remaining 5.
Is that okay? Okay. Is that what
instead of them discarding, were they trying to also monitor so they will push the other 5? If not, then I think 4 mils of aqua plus 1 mil of hydralazine will be 5 mils. Instead of them taking 2 and mixing with 8 mils of water.
Yes, I get it.
So please, I want to know if the plan was to keep the remaining.
Please, we didn't discard. You realize that the BP and the patient was in a hypertensive crisis. If you look at the BP range, that was hypertensive crisis. And we have to manage at that point now, we have to try to bring the BP down, not just like after which we discard. The next shift or the next people have to also take over that. But that was how we managed before I left. Okay. So we handed over the other 5 milligram of the hydralazine to the next staff.
Okay. Okay, it's well noted. It's well.
All right, thank you.
I think he wants to say 5 mil, not 5 milligrams. So Felicity, I'm sure it's rather the 5 mil he wanted to say. Yes, and then definitely it will be later used because this thing sometimes you can sometimes see a fast drop, and sometimes also the BP will be fluctuating, and so you need proper BP management and BP monitoring. And then I'm happy with this case scenario, and it will also edge us all to know how to face this. I'm sure most of us haven't faced this situation before. At least when you are faced with this, you know how to manage it. Go and then read up more about the diabetes regimen in terms of managing this case. And then mostly also when we have hypertensive emergencies, what is the first thing you're supposed to do? What is the first thing you're supposed to do? When you're faced with these two, both the BP high and then the RBSI, what are you supposed to do? That's the first thing. After here, let's all go and then read about it so that when you are faced with it, you can manage it. Henry, let me see. Henry, where are you? TTH.
Yes, I'm here.
Yes, share an experience. Share an experience with us.
So, madam, in my ward, at the gynec ward, we've actually been managing lots of cases. Like you have a patient who comes maybe with just like my brother shared, patient comes with maybe like preeclampsia, so the BPs are skyrocketing. You also have the same person being diagnosed with like diabetes, and sometimes you have to try to consider the two conditions and then manage. Aside that, you might have a patient being managed as a case of, let's say, cervical cancer, the same patient having abdominal uterine bleeding, a whole lot of conditions like mixed or fused together like that. And you have to manage the person. Sometimes most of these patients even end up dying. You have to even do chemotherapy for some of them. Some of the chemotherapies that you even do is just like, oh, some form of like palliative management that you have to actually do, and which is actually so heartbreaking sometimes. And so with some of the cases too as well, they're actually straightforward. Let's say the patient comes with, let's say the patient is pregnant, the patient later expels, and post expulsion, just as the patient came and maybe the pregnancy was threatened, later the patient expels. But later you get to understand that the patient has some other gynecological issues, which eventually would even lead to the patient dying. There was a patient who came and they had to induce her to expel. Now, post expulsion, you realize that this patient had other, I think, cancer of either the cervix or so. So we managed this patient continue. So the patient had to stay in the ward continuously like that for like several months. The husband was actually trying, doing so well, doing very well, buying all medications. If you call the husband to do this, the husband is there. If you do this, like emotionally, we're even with the husband. Even at a point, she was not even chewing ice block. Like she just wanted ice on her tank just to be taken. That was what she actually felt like taking. She had even wasted bedridden. Meanwhile, this patient just came with the mind that, oh, my pregnancy is threatened.
Yes.
They have induced me to expel, and now these are the issues.
Yes.
So this is just something smaller as well.
That's great. That's great. So mostly we are faced with a lot of challenges where how do we even start with our care? Sometimes you prioritize some care and you realize that about the first three priorities, you don't even know which one you even have to attend first. They are all urgent. They are all urgent. And that is where we are faced with also ethical dilemmas. Yes, Festus. Festus.
Yes, madam. Good morning.
Good morning, Festus.
Madam, my experiences are many, and I have a good ending and bad ending, so I don't know which one I can go with.
Share the two, please.
Okay, so the first one is in the ward. One of our colleague was running night, which I was also running night. So I was running night at the pediatric ward, and my colleague nurse, who is a female, also was running night, also at a female surgical ward. So all of the sudden, she was resting on the bed and had heart stroke and attack, but mild one. So as the attack came, she picked the phone and was able to call the husband. That was what she could do. She couldn't call anybody, and the one who she was running the night with had also slept. So yeah, so I was passing by when I peeped through and saw that she was lying quietly, but I thought she was also off. So I walked by, and when she called the husband was also coming, but she was also able to pick the phone and call the staff colleagues. So they also came and was standing, but by then she had gone unconscious. You could, when you tap her, she doesn't respond, and they were just watching. So when I also passed by and I peeped through the wardrobe and I saw that they were also standing around her, I also left my ward and entered. So when I entered, I saw that, oh, they said, oh, all of a sudden she called and they came and she can't talk and she's sleeping. But I could remember that she discussed with me some time ago that she's having stress in the family. She doesn't rest and was talking about she had BP and they have advised her. So because of that, I quickly said I suspect she's having hypertension. So I guess picked the BP apparatus. When we checked, it was actually high. So when it was actually high, I was a junior. So those I was standing with which were my colleagues, they were seniors. So they decided that we should observe, which I didn't want to agree. But you know, when you are with your senior, sometimes you
Yes,
have
sir.
to.
Don't end that your colleague next died, though. Don't end that. Oh. So you continue.
I
But
know she
don't.
didn't die. She didn't die. So after 20 minutes, I just came back and told them that look, be
Festus, we want to listen to your happy ending, please. Are you off?
crisis. So he also started the treatment, and from 30 minutes going to 1 hour, he started dropping a bit. So after 2 hours, that was even then the following morning, then she now began to gain consciousness. So by then the treatment has started already. So
What did you give? What did you give her?
no, I didn't start the
The
treatment. You know
basic-
that there's a protocol for that treatment, and it
Yes.
was
So
IV
what was it?
hydrolysis. IV hydrolysis. But I was not the one giving.
Okay.
I was not the one who gave it, but they were waiting to observe. And if they had continued to wait, it would have gotten worse. So after they gave the treatment, and after 2 hours, she now began to gain her consciousness. And the following morning, she was able to sit up, and eventually she recovered fully. Nothing happened to her afterwards. So after that, all my senior nurses, they came and told me that, oh, that I did well. That for me to have just say, oh, let's gather the courage and go ahead, because if we were going to observe, and the following day they also came and uh, the nurse herself also came and thanked me that, oh, she was unconscious, but they narrated the whole story, how it happened, and I told them that they should go ahead and treat. So what I have also learned is that though they were senior, you know, sometimes some of us we don't actually agree that a junior can draw your attention to something. So if they have not agreed with what I have said, I don't think if you are down by stroke and you are still waiting, I don't know what you want. And another story too was that it's the same case. A lecturer, which that one is the sad story now. A lecturer was also defensive and came to and went to this thing to pick the kids from school. So as he was picking the children, immediately he got to the house. He had a hypertensive crisis and was having seizures and all that. So they rushed him again to our hospital. So when he arrived, the physician on duty also uh, also was there and prescribed nifedipine. I think it was a 40 milligram tablet. So and when we gave, it was not coming down, and he added some infusion. So we were three on duty. So we reported back that it is not working. The BP is still so high, it's not coming down. But he refused to intervene again and wrote the referral. So we call
Oh.
ambulance. Yes, we call ambulance, and but at that time I was very new into the job. Just 2 months into the nursing. Yes. So as he was he prescribed the nifedipine. It was not bringing the BP down, and it was also by oral. And the next step was just to call ambulance and refer. So as we were trying to refer, the patient was convulsing, seizures was coming up, and we couldn't stabilize the patient. Yet we were still in the process of transferring, and even he was diabetic as well. The sugar level was also high, but he didn't also attempt that aspect. And eventually, we just managed to try and refer to a teaching hospital. From there, they also managed somehow, because the relative, we took their contact and was asking what was going on as we referred them to the next facility. So they
Was
also
the doctor
referred.
a house officer,
No, physician
a
assistant.
medical officer?
Yes.
No, sometimes
So
you guys have to know their rankings. So, physician,
yes,
what? Is it a medical officer? Because medical officers also as well, they are just like, you are done with your rotation, you started work. So most
yes,
people also don't know anything. No.
yes. So
Sometimes
when they
you have
also
to prompt them.
yes, so when they also got to Accra, they didn't also they were not also able to help him, and he eventually passed away. So when we heard the news, I began now to also reflect on it, and I also thought that, oh well, if we have also done much, because I don't see a situation where
Yes,
there
yes,
is
yes. It
hypertensive
started from
crisis
your
with,
end. Yes,
yes, with diabetic high blood sugar
yes,
level, and you are starting with oral in the first place. It's
yes.
even a no-go area.
It started from your end. It started from your end. So all these things, at least, it will guide us to reflect on the things. Thank you, Festus. Thank you, but I'm not happy about the second case scenario. But what else can we do? It will just guide us as to know the things we are supposed to do when we are faced with emergencies. Sometimes when the physicians are writing whatever, let's question them. Of course, if we are new, that one, of course, we are new and we don't really understand the system so much, so I get it. But at least our seniors, those of us at that time, I'm sure Festus had a senior on the ward. Didn't he or she say anything to the doctor? Nifedipine oral, even nowadays, even if you want even to give an oral, it should have even Nificat Excel 30. Then they take it sublingual. But there's the normal, the nifedipine. No. Nowadays, it doesn't work. And then mostly you get the fake ones as well. That's so bad. Thank you all for your input. I'm so grateful. Grateful. We have, of course, I've talked about the reflection on action and inaction. So this is the most common form of reflection. It involves rerunning of events in the mind. This helps to understand your strengths and to develop more effective ways of acting in the future. And then in action, they say it can only be done by an experienced person. It means examining your own behavior and that of others while in a situation and then you do that. Mostly if a connection can be drawn from a previous experience of a similar event. Now, I'm sure if Festus is faced with any challenges like this, oh, quick. You know what to do. Even do that even before calling on whoever physician is available, because now you and I know that they also are quite green in a way. Sometimes also they have to also, medical work, health work is all about the number of years you have practiced. It's about that. You have to let you know more when you are in it more. That is why mostly we, the ones who have left the clinical field, we want to find ways and means and then be able to join in a way. So maybe sometimes if you want to do a part-time work somewhere, or once in a while go and sit by your colleagues who are still in the clinical field and be chit-chatting before you realize you are picking up one or two things, especially those who have left there for long. Sometimes it's all about theory and the practical bit, it's quite missing, and it shouldn't be missing. If ideally you want to be the ideal academicians, then it means the clinical field should be part. In the developed countries, you see professors in nursing, and they are teaching as well as having a bit in the clinical field as well, so that when you're faced with all these challenges, you know what to do for these patients. So, theory of nursing practice, of course, in reflection in action, reflective journaling, it addresses basic human needs related to the physical and mental well-being of patients and related others, including ourselves. And based on all our discussions, we've understand this point so much. In our hospitals or any other clinical field, any other clinical related facility, nurses have important role in addressing this basic human needs related to the physical and mental well-being of the patients, themselves, and their relatives. If you work reflectively in this setting, it's important that we as nurses, we know all these things for a lot of reasons, for emotional cost, even to we nurses, as we've discussed it, in caring for the patient who has just different levels of needs. And it helps as a result the nurses being even confronted with all these human needs, which are well planned and should be well implemented, so that on a daily basis, all the anxieties and worries will be on the minimal. Integrating reflective journaling into our nursing education. I'm sure in our diploma level and even, yes, it is not so much in, I don't really know about the curriculum there. And even with our degree as well, it's not, you don't find it all curriculums. Ideally, it should be incorporated in all curriculums so that we will know that, oh, reflective journaling should be part of us. If not on a daily basis, let's say on a weekly basis, we can write something. Every nurse has an experience. Every nurse has an experience, both with the patient or patient's relative, or even our colleagues. All those experiences are things we can reflect on and be a better us. Providing guidance and support. Of course, if you are not guided, you didn't know that there's something even called reflective journaling, and I have to write it, do it this way, that way, to get that experience, that positive outcome out of that thing I've written, so that next time when I'm faced with all these challenges, I can as well deliver. Then, demonstrating its value for future nursing practice. So, as we are on it, as we are doing it, we would have this positive feedback and knowing that, oh, this is still of importance. It's of importance, and so it should be something even better in addition to the reflective journaling that will guide us. That will guide us. For now, we've learned that the workshops that we have to go are of paramount importance. The appraisals that we have to write, we shouldn't wait and do a cut and paste when our colleagues are done. Hey, are you done? Give it to me and let me write. After all, we are in the same rank, so our job description is the same. So whatever you've written, for all you know, even knowledge-wise, we all know that knowledge-wise we are different. Maybe what you will think that you are lacking, she's not lacking. And you see that mostly for the training, where I was, for instance, for the training, infection prevention, every time there's workshop on it. What else do you want to know? With regards to infection prevention, of course, it's good we know we add on always, but there are so many things we are supposed to be taught on the job or maybe in-house, but we are not writing them. There are things that we don't know, we feel that we know, but we don't know. When we are faced with challenges, then we are found wanting. So let us try our best and incorporate reflection or reflective journaling into our nursing practice, and that will guide us a lot. We are done for today. Thank you very much. If there are any questions, let me answer them. Or maybe the class will also help answer them. Any questions? Any questions? Okay. So if there are no questions, next, how many weeks do we have more? Is it 2? how many weekends more before exams? We have we have next weekend and next 2 weekend or 3.
Two.
2 weekends more. All right. So we have management and then patient-centered care as well as patient family education. The patient-centered care and patient family education is combined. Then ward management. We'll say if because the last day, I think I would have to discuss the end of sem a bit with you. So I'll try and see if I can leave some 10 minutes or 15 minutes on the last day. That's next 2 weeks when we are talking about the either ward management or patient-centered care. Then we discuss it a bit. Thank you very much and have a wonderful weekend.
Thank you.
Same to you.
Thank you, Ma. You too.
Thank you, sister. Bye bye.